Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one size fits all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Welcome to Talking Therapy. This is Marvin Goldfried together with his most esteemed colleague,
Alan Francis. Good morning, Marvin.
Good morning. You didn't know that you were esteemed, at least
at least from you, not necessarily from my wife, but go ahead.
But listen, Alan, in our last podcast, you made a statement which I found very hard to believe. You said that you said that human behavior is too complex and research will not allow us to move forward, essentially. This is not your exact words, but you were kind of saying research is not going to help us because human behavior is too complex and we can't codify things. Does that capture?
Well, I think psychotherapy research has been enormously useful in terms of establishing the effectiveness of psychotherapy. And it's had a great positive impact on the world, and that governments and insurance companies are now much more likely to compensate people for doing psychotherapy.
But and I agree with that. But above and beyond that, we're talking about helping the practitioner.
I'm very positive about outcome research, less positive about process research and about research that compares two types of psychotherapy.
Okay, so you're not against research generally, but certain kinds of research, is that?
Yeah, I'm very positive about outcome research. I think that's enormously valuable. Okay. I'm less positive about process research that tries to understand exactly what worked in sessions. And I'm sort of negative about research that compares two kinds of psychotherapy. Yeah. I think that's been done enough already, usually results in high scores, doesn't further things that much.
Okay. Well, let's start off by defining certain terms, because I think there's a lot of confusion in the field. And I'd like to talk about evidence-based practice, which is often confused with empirically supported treatments. And I think it's the empirically supported treatments where you may feel that this is not really the best way to go. And these are empirically supported treatments of kind of a model after drug research, in the sense of two or more clinical trials where the active intervention is better than the control. And then it gets a certification of being empirically supported. That, I think, has been what people think is research, period. Kind of the results of clinical trials, which is touted as a, quote, gold standard. So when people talk about research in the literature, they assume that all research is what comes out of clinical trials. Now, I don't know where you stand on that.
I think, Marvin, we should let you go for a while so that I get the gist of what you're going to say, rather than having me interrupt piecemeal. So why don't you go ahead and say how you see it?
Okay. So my understanding of evidence-based practice is it says any kind of research that is relevant to clinical practice should be used. Any kind. In addition, we need to look at patient characteristics and what their needs are and what their environment is about. And as a third variable, therapist expertise. And those three things, or it's sometimes called the three-legged stool, should be taken to mean evidence-based practice. So that's where I stand on that. So the key is, what is research? And there's different kind of research depending on the questions that are being asked. So outcome research, which was later changed in its terminology and methodology to clinical trials, is, does this make an impact? Does this intervention work, is the question. But there are two other very important questions. And that is, how does it work? And another question, what do you have to do? What do you have to focus on with any given patient with a given problem? So what do you need to change? How does change occur? And is change effective? Those are the three general research questions that I consider to be key. What's your reaction to that?
You're on a roll. Keep going, Marvin.
Keep going. This is going to be a monologue. I thought we were going to here. I was looking.
I think it's really good for you to have an uninterrupted opportunity to. You've thought about this more than anyone for the last 40 years, and I think it's good to hear you out.
Okay. You want me to put on my professorial hat and give a lecture, essentially?
Well, do whatever comes naturally, Martin.
But I mean, after 60 years, that comes most naturally. And my family has to shut me up on that. She says, "You're not in class now. Just talk like a person." Anyway, so back in the 60s, I think it was the 60s for the most part, when we first started doing outcome research with simple type stuff, phobias, fear of public speaking, fear of touching snakes. You do a pre-test, you do an intervention, you do a post-test. And we found, much to the disbelief of our psychodynamic comrades, our colleagues, that it worked. They couldn't believe it worked, but it worked. We were able, these are the very early days of behavior therapy in the 60s, we were able to reduce these fears and phobias. And it took a while before psychodynamic therapists finally did agree that maybe there is something here. So that's what I consider outcome research. Does it work? And yes, it was exposure, originally imaginal, but then later on in vivo exposure, and often with the ability to relax and cope with whatever anxiety. Basically, it was, try it, you'll get used to it, was the principle behind that. So
one little interjection here. I started training in psychiatry in '67, and we had on the faculty at Columbia many psychodynamic supervisors, but we also had Howard Hunt, who was one of the early behavior therapists, and you may have known Howard. So we got the combined view that it wasn't that one school was right and the other school was wrong. The way we were trained was that with some patients at some points, Howard Hunt's approach was going to be better. With other patients at other points, the psychodynamic approach might be, but these weren't contradictory, competing two styles of therapy, that these were different techniques that would be used at different times.
Right.
I remember early in the 70s, Ben Feather and John Rhodes, who was later on my faculty, wrote a paper on combining behavioral techniques with psychoanalysis to understand and decondition unconscious fears.
Yeah.
I grew up in an atmosphere where it didn't make sense to see these as competing.
No, and I'm not talking about competition at this point. Because it could simply be a weightless control or some other kind of control. It doesn't have to be a competitive type of thing. It's just outcome research. And we did outcome research on other kinds of problems that were more likely to occur clinically, like passivity or unassertiveness. And we were able to really get people who were soft-spoken, not getting what they want, and get them to speak up, but not in an aggressive way. So the focus, that was outcome research. This is stuff that we did with Marsha Linehan when she was a postdoc. We were able to get people to become more assertive. And lots of people did outcome research on assertiveness, and found that not only did people become more assertive, they became less anxious, less depressed, more self-confident. Okay, this is the kind of outcome research, which was wonderful.
And I was very much influenced by it.
Right.
It struck me as very important to focus on symptoms for many of the people coming into treatment rather than underlying personality problems.
Right.
And around this time in the 70s at Cornell, where I ran the outpatient department, we started a very large brief therapy program. And we had each of the residents have at least one case that would be involved with behavior therapy, one with cognitive therapy, and one with psychodynamic therapy.
Right.
They could learn how to do each and then combine it themselves with patients. So I think that research literature had an enormous impact.
I agree. And I contributed to some of that and got NIMH funding. But then I got a word from our mutual friend, Barry Wolf, who was a staff member at the NIMH, and he came and visited me, and he said, Marv, we can't fund your research anymore because you need to have a DSM diagnosis, and it needs to be, and you need to use a manual. Now, we were using manuals. We had manuals. So that was not the issue, but it was a DSM diagnosis rather than none of this treating phobias, none of this treating unassertiveness, none of this treating procrastination. We need to do the DSM. And then we had 40 years of clinical trials. So the current generation of clinicians and researchers, the new generation, don't remember that there used to be something back then, which was really, really useful. And then it became medicalized, get the diagnosis and do the intervention.
Well, would it have made it such a difference if you submitted the grant under the rubric of social phobia?
Oh, we did some social phobia stuff too. Yeah.
I mean, in other words,
I know. Yeah, there were different ways to get the grant, but look at what social phobia is. Oh God, if you are anxious about urinating in public, you would get the diagnosis. If you were anxious about giving a presentation, you would get the diagnosis. If you had difficulty interpersonally, you would get the diagnosis. So all the research in the 60s and 70s and beginning 80s, say on public speaking anxiety, have been ignored now because nobody searches public speaking anxiety for articles. They search social anxiety. So and what do? They treat public speaking anxiety, and then they generalize to social anxiety, which covers a broader class. So this was the poorly thought out notion of clinical trials, which is now seen as research and evidence. So prehistorically, historically being the advent of clinical trials mandate in the 80s, we had more focal types of outcome research. So that is one kind of research, and that answers the question, does the therapy work? Now, you don't like process research. Why don't you like process research?
I think that an enormous amount of effort has gone into it with very small output. So one part is a practical concern that it doesn't lead to much change in clinical practice. The second is more theoretical, because I think it implies that we can figure out through research what clinicians should do in their office with their next patient responding to this or that problem. And my sense is that the field of clinical practice is so remarkably complicated with so many uncontrollable variables, including the nature of the relationship, that science is always reducing the complexity of a situation to something simple so you can control the variables as much as possible and interpret what actually made a difference. I don't think that's possible in the psychotherapy situation because there's so many uncontrollable variables.
Well, okay. I disagree with you that it doesn't have implications. I think it has very clear implications for clinical practice, and I'll get to that in a minute. But you're saying now that there's so many other variables that make it hard to understand process research. Well, these are the same number of variables that make it hard to understand outcome research, which you say is good.
No, it's different, because in outcome research, it's simple. Did the person get better or not? And what needed to be demonstrated in order for governments and insurance companies to pay for psychotherapy was patients got better. And they got just as much better with psychotherapy, or maybe even more better with psychotherapy than they did with meds. The conclusion is we're prescribing too many meds in the population. We don't have enough therapists. We should be paying.
Okay, so your argument is from the point of view of psychiatry, of making the case to other psychiatrists that, hey, this psychotherapy stuff is also good.
No, it's not psychiatry. It's a matter of convincing
insurance companies. Okay.
Insurance company and governments. And Europe, particularly, the government decides who gets what kinds of treatment. This, I think, has had, and I know it's had in many countries, a dramatic impact in increasing the funding for psychotherapy. Ono in Japan did CBT studies. Now the Japanese government.
Okay, listen, I don't want. Let's not get into politics and economics at this point. We can talk about that. Let's talk about research and
Marvin, one caveat. I think that's the most important question. We can avoid that today, but I think that the reason I'm such a strong supporter of outcome research is it really did change the world.
I totally agree with you, and it's a question we can deal with at another time. But the topic for today, as far as I understand, is, does research help the practicing clinicians? And I say yes. And with regard, we've talked about outcome research. Now we're talking about process research. And let me give you an example of how process research can help the practicing clinicians. This is the research done by Les Greenberg. I don't know if you know Les Greenberg. Okay. Les Greenberg is a psychologist. He's now retired. He was at York University, continues to give workshops. He is an interesting guy because his orientation was a blend of Rogerian therapy and Gestalt therapy. So he does kindly Gestalt therapy as opposed to Fritz Perls. But he also does therapy research because he had a master's in engineering. So most of the people who deal with the Gestalt experiential stuff have this fuzzy thinking, and they say, you can't do research. But he has a research mind, and he has done process research to show that you manipulate certain kinds of interventions, or you engage in certain interventions during the therapy, and it produces a positive outcome by the end of therapy, by the end of the session. And that these positive outcomes at the end of the session eventually lead to therapeutic outcome. So he relates process research to outcome within the session. So somebody may be talking to an empty chair about some unfinished business with a parent, and they're kind of slightly annoyed. In order to give meaning to that reaction, he needs to get the person to express more emotion and to get more angry at the significant other, saying, I'm angry at you because you didn't give me what I need, and blah, blah, blah. And he found that as the level of anger goes up, there's a greater likelihood there's a positive impact at the end of the session. So, clear implications for the practicing clinician.
Not exactly earth-shaking to me. Aristotle introduced the term catharsis 25.
Well, it's not quite catharsis. It's different. It's that true meaning structure in the sense of the pathological or problematic meaning that is causing problems in the patient's life has to be elicited during the session so that the person, why are you shrugging your shoulders?
So no?
No, but yes. What about outcome research? You could say the same exact thing.
I mean,
you do it, you get used to it.
Has there ever been a therapy training program that said it wasn't a good idea to allow people, to encourage people to express their emotions about the experiences in their life.
But where
it's gilding the lily. It's kind of
but there
so
are
obvious.
certain. Well, listen, you've also acknowledged that there are therapists who follow a school of thought and what they do is determined by theory rather than good clinical common sense.
Right.
So what we're doing is the research is validating good clinical sense. Is there a benefit to that?
If there is, I mean, again, I wouldn't argue that it's true. I wouldn't argue that it's maybe useful to have a study that says that what you always thought was true and everyone always thought was true is true. But I don't know that that's going to really change the world that much. Many people may have the reaction I do to this, that, yeah, it's obvious. What does it add to what we already know?
Okay. I think it validates what many therapists know and many therapists don't know or don't do, and maybe it will call attention to them trying this. You're saying it has no value whatsoever. Well, there may be no value for you, but there may be value for other therapists. But let me, before we finish for today, let me get something else in. Okay, so outcome research says, does the therapy work? Process research says, or addresses the question, how does it work? What needs to change? Now, here we have basic research on psychopathology, on depression, on anxiety, basic research on human functioning, on cognition, on emotion, on action. I personally find some of this basic research more valuable than some of the outcome research. Case in point, in social psychology, there's research on attribution and misattribution. And that is attribution being in an interpersonal situation. Well, this is one example, there's more. In an interpersonal situation, I'm reacting emotionally to the other person because what I attribute their motive to be. So if somebody is not talking to me, I'm assuming they're angry at me when they just may have some concerns that they're dwelling on. A lot of interpersonal problems are a function of misattribution of motive. We call the person selfish when really they may be behaving a certain way for totally different reasons that have nothing to do with you. Is there relevance here clinically, do you think?
Sure.
Okay, so that's basic research from social psychology. There's basic research on expectations. There's basic research on cognition and on emotion. Correct me if I'm wrong, but in medical school, did you have to study the functioning of the body?
Sure.
Why?
Well, most of it wasn't really that helpful to practice even in medicine, but it was the idea being that it would be useful preparation for what you would do later on. And I can see the analogy and I'm for it.
Okay. So we need to know more, or therapists need to know more about how people think and their distortions. The research of Kahneman and Tversky on judgment,
Sure.
which is profound stuff, is very, very directly related to the clinical phenomenon, where they talk about people making predictions, okay, on the basis of faulty information. Well, our patients make predictions all the time. We call it anticipatory anxiety.
I see the Kahneman and Tversky work as a kind of scientific study and confirmation of Freud, the fast and slow types of thinking.
Yeah.
Exactly what Freud was talking about. I think cognitive science, I'm not criticizing cognitive science.
But that's research.
No, I'm very much for cognitive science. What I'm not thrilled about, or not nearly as enthusiastic about as you are, is the kind of process research that claims at the end of the day to be able to say that this particular technique will work with this kind of patient. Because I think in order to do that kind of research, you've narrowed the number of variables in the room to focus on one, missing all the others. And when you do comparative studies, it always turns out to be a tie score anyway.
Yeah, but you can still do research by holding these other variables constant. You can say, well, you can say, I want to work with a person who's perfectionistic, who is X, Y, and Z, has these characteristics, has this IQ level, is functioning at a given level. And we want to try out a certain kind of intervention with these individuals. Preliminary research on that could be done internationally very, very easily.
But my point again, Marvin, goes back to the Rosenzweig paper. My guess is that the nature of the therapeutic alliance, the personality of the two people, the things that are outside the realm of what's being studied will be much more powerful than the specifics of what's being studied.
That's an empirical question, because all these things can be held constant and not vary from site to site or from individual to individual. You can say, I'm going to take a very small class of variables and only manipulate one of them, only, the degree of perfectionism or whatever it is. And we can get ideas for this kind of research from practicing clinicians who say, I think this is what I see. I don't know if it's a reliable phenomenon. Let's find out if other people see it as well. That's also research. And that's therapy research.
I think we'll agree to disagree. I don't inherently think that it's not useful. I just think it's not useful enough to really devote many resources to. We both agree on the value of cognitive science. We're both very strong supporters of cognitive science. I think we both agree that in certain arenas, at least, outcome research has been very useful in a practical sense. I think where we disagree is whether we'll be able to tease apart what's most important in sessions, because I think it's way too complicated and not likely to help the clinicians that much in the future. One other type of research that I wish we did more of is cost offset. So the kind of outcome research, if we could provide studies that showed that psychotherapy reduced other costs over and above the cost of psychotherapy, for instance, for medical visits, for emergency room visits, I think that would be another. I'm trying to get more psychologists and psychiatrists out there doing psychotherapy, much more than I'm worried about will the research help them know what to do once they're in the room. I think we need more total resources, and that's why I'm so strong.
I don't disagree with that at all, but that's a whole totally different issue, because that does not give the guideline to the practicing clinician, which is what I believe is the core theme of our podcast today. What can we tell the practicing clinician that could be helpful to them? And the prior question is, what do they want? Because we don't often do research on what the clinicians want. We do research on what gets funded, which is a political and economic issue in itself, certainly.
I think what we can tell the practicing clinician based on the accumulated research, such as it is for the last 50 odd years, is one, that the relationship is enormously important and non-specific factors are enormously important. Two, that there's not going to be a clear winning therapy. It's not going to be cognitive therapy wins or behavior therapy wins or psychodynamic therapy wins or systems therapy wins, that all of these are useful techniques. And that this is what you've been doing for 40 years, that what the therapist needs to know is he needs to know a lot of different techniques and be flexible.
Well, she also needs to know lots of other things, but I think they already know this. They know that the therapy relationship is important. They know that not one single school is not going to do the job with all patients. Something that is already known. And I'm talking. I think there is survey research to demonstrate this, Alan.
Yeah, but there's still a tremendous amount of guild interest in defending one form of therapy against the other.
Of course there is, yes.
So they don't know. Has it been integrated into training programs that we're going to make everyone flexible rather than we're going to train them this specific way?
Okay, this is, we should get somebody as a guest who is involved in dissemination research. So if anybody is watching or listening and knows a lot about dissemination research, of how do you get the research findings so that it's used by the practicing clinicians, please contact us. You can get our emails by just going online and entering our names, and send us an email, and that would be great to have that. That's another.
So we're agreeing that that's another. It's not as if this quote's knowledge about flexibility and complementarity is so widely disseminated to the world that training programs are teaching people to be flexible.
Right.
It's not as if everyone's coming out of their training program saying, I want to be sure I know all of these techniques rather than be identified with one school.
Alan,
that problem is enormous.
Alan, if that problem was solved, I probably would not be talking to you in this podcast because that's what I'm still doing, trying to continue to pull the wagon.
And you've been the pioneer at this for 40 odd years. And what I'm saying is, I don't think that process research is going to solve that problem. And that's the elephant in the room.
Well, and that's where I disagree. We'll have to agree to disagree and come back to it maybe some other time. Nice talking to you. Have a nice day. Stay safe.
You too. Bye-bye.
Bye-bye.